Good afternoon, everyone. It is 3 o'clock, the witching hour on this creepy and cold Halloween day. I want to thank you for joining the call today. I've entitled it Fall's Rewind, and if you have signed on to the webinar, I wanted to add a little Halloween clip art, and I thought that this one was quite appropriate, that I found a nice little elderly lady standing in the door of her house with a cane. So we're practicing good clip art fall prevention strategies. So anyway, happy Halloween, and as I said, thanks for joining the call today. So today I really kind of wanted to review some hen data and show you where we're at with our fall improvement journey. And I want to talk about a couple of targeted interventions for fall prevention, and then review some resources as well. So those will be our objectives for today. So I like to always include this slide whenever I present on falls, because it is really quite an impactful statement that every 20 minutes an older adult dies from a fall that occurs in the United States. And there are many, many more that are injured and not even reported. And so if you think about that, one fall every 20 minutes, it's pretty scary. On the flip side of that, to kind of give you some encouragement as you work so hard to keep your patients safe, there's fall prevention, and there's opportunities and harms prevented as well to keep your patients from not being one of these statistics. So to start us off with the HRET hen goal, nothing new here. We've been living it for the last couple of years, but it's a 20% reduction in patient falls by 2019, which is, hey, now. This goal goes back to the original Partnership for Patients. It was originally, if you remember, if you were involved in the work back then, it started off with that big 40-20 rule, which is 40% reduction in harms and 20% reduction in readmissions, and not an easy feat by any means. We're all still trying to continue to drill down, and I think it took us 2 years just to figure out what we were all doing about fall prevention or any of the harms prevention. And so anyway, that has been our goal, and this is where we're at right now. So my data that I have been able to collect, that I had the most months collected, was reported through the month of July with falls with injury, and we are at just a little bit over a 19% reduction. And I will tell you, we're probably closer to 20 now, because we have gotten a lot of data that has been entered in for August over the last week, maybe a week or two. And so I'm sure we're probably have hit the 20% improvement mark. And we've been going between 19 and 20% probably for the last 6 months. And so I really want to go like above the 20% to finish the year off. And so, I kind of wanted to bring us back together just to talk about that. Our monthly baseline numerator, so that's how many falls with injury are occurring on a monthly basis for all 92 of our hospitals that are participating in the HEN, is about 151 with 226,000 patient days. So of 92 hospitals, we're averaging about 2 falls per month per hospital, a little under 2 falls. So that's not bad. Obviously 0 is always where we want to be, but that's not too bad, unless, we have a hospital who is very much exceeding those 2 falls. But I thought that was an important number to know. But when I look at this number, this is the number that kind of makes me gasp a little bit, even though it does go back from October of 2016 through July of 2019, we have had almost 2,600 patients in our 92 hospitals that have experienced a fall with an injury. Those injuries range anywhere from a bruise, abrasion, skin tear, all the way up to fractured hips and subdural hematomas. So big range there, a very big range, but we still have some work to do. But needless to say, you know, we've been on the right path. But when I look at this, so this is a snapshot of what we look like when we put it on a chart. And as you can see, our baseline is actually the green line. So that's our target. That's where we want to either go to or be below it. And as you can see, we really kind of go up and down, up and down, up and down. And when I see periods of, oh, wow, we're really doing good, then we have a couple spikes here and there, and then we drop down, and then we spike again. And so, you know, we're really, you know, we kind of see we're not really hardwired any consistent practices. But I am going to be optimistic that for the last 6 months, it appears that we are, you know, staying closer to that line. I just want to fall down beneath it. Easier said for me than for you, but I just wanted to show you what it looks like on a graph. This is what HRET looks at when they look at Indiana as a state. What kind of activity is Indiana showing? And so when they notice that we're climbing back up, they might tap us on the shoulder and say, hey, what's going on in Indiana? Are you going to be looking into this? And so this is the snapshot that they look at. So I broke the numbers down, and of the 92 participating hospitals, we really have about 14 hospitals that are making up about 78% of our total falls of almost 2,600. And so a couple of these hospitals have been a part of our Falls Collaborative. I might be doing an outreach to some of these hospitals and just doing a check-in to see, you know, I know that so many hospitals are working so hard on different programs, and you know, if I need to do a one-on-one, come and meet with your Falls team, or your safe mobility team, I would be more than glad to do that, and just kind of see where your barriers are and how we might be able to help with that. So, you know, when I look at that 14 hospitals of 92, you know, I really kind of want to reach out and find out. And I know that some hospitals have some really good rationale behind that. And so I'd just be curious to see where we're at with those barriers now. So let's talk a little bit about what you're doing to reduce falls. So I had a webinar with a group of hospitals that participated in a Falls Collaborative a couple years, year and a half, 2 years ago. And they brought up some concerns, and this is nothing new. For years I've called these the if patients, and that is the impulsive faller. Those are the ones who, they don't fit your typical category. You know, the little elderly confused patient that keeps climbing out of bed, or you know, the repeat fallers or things like that. But rather, they could be that group of patients that cognitively they are quite intact, but they are the ones that their head and their bodies do not work together. They think they are just fine, and they go to stand up to go to the bathroom, they get dizzy and they fall, or their knees collapse, or they're a little bit weaker than what they thought. Those are the ones that talk staff out of assisting them to the bathroom or staying with them in the bathroom. And, years past when I did falls education, I was really heavy on working on scripting with our staff, especially our techs, who are the majority of the time, those are the ones that are taking the patients, getting them up, to the restroom and what have you. And it's not always an easy conversation for them to tell the patients that they have to stay with them in the bathroom, or they have to assist them to the bathroom. And so that's where the scripting comes along. Along with the scripting comes, it's a teach back, and HRET has this teach back tool. I only made a little screenshot of the very first page, and it seems kind of cumbersome, but this is something that, you can have a tech do with your patient. It doesn't always have to be nursing. And I've actually, I was doing some research on looking for some new information to present to you guys. I did read one hospital system is training their volunteers to sit down and do these fall prevention and education promotion of materials with their patients. I thought, what a wonderful idea, because it's just really getting to know the patient and kind of finding out where some of their strengths and weaknesses may lie. So, if you have some impulsive fallers, I would encourage you to go to the HRET website and check out the change package, and this is included in there. And maybe you can have a unit that you can just trial this on. Perhaps it's your surgical unit, and it's your patients who, are in that age category, the 50 to 60-year-old patients who think that they are better than they are, and those are the ones that are falling and hurting themselves. So anyway, take a look at this resource, and then think about who might be able to be the person who would do this little survey with your patients. I also received in my inbox just a couple days ago this report from ARC, and I scanned it when I got it. And yesterday I dissected a little bit more, and most of you who work with me know that I also do the Culture of Safety survey, and I teach Culture of Safety. And so this one really jumped out at me. And this is a survey from ARC, and it's actually on post-fall huddles. And I know we've talked about this in the past, and it's nothing new to you, the significance of post-fall huddles. And for the most part, I believe that people are doing post-fall huddles. But this report really dug down into, it was a study done, so they really dug down into the safety culture and looking at what is the culture of your hospitals that would make a post-fall huddle a tool that would be a preventative measure, or that would help with perhaps readmissions or any other events that are surrounding the fall risk. And so just two things that I just wanted to point out to you. And as a reminder, all of the presentations have links to all of these resources. So wherever you see the bright blue underlined, that is actually the website. We will be posting this presentation along with the recording to our website in a few days' time, so you'll be able to access it there as well. But everything that I'm including in here has links. So wherever you see the bright blue, this is where you can get this information. But the method that they actually use the Team Steps Teamwork Perceptions Questionnaire. And if you're not familiar with that, it's kind of like a mini Culture of Safety survey questionnaire. So they use that for the hospitals that were Team Steps, and then they use the HSOP survey, which is the ARC survey. With their others, they assessed their culture of safety, their perception. How does staff perceive safety? The results of their survey, they found that repeat fall rates were negatively associated with the proportion of falls that were followed by a huddle. As compared to hospital staff who did not participate in huddles, those who participated in huddles had more positive perceptions of the 4 domains of safety culture and how team structure, leadership, and situation monitoring supported fall risk reduction. So what that means is fall huddle actually promoted teamwork. It actually helped people work together a little bit more. It helped people understand, and what that led to, you say, well, how does that lead to prevention? What that led to, it made the function of the team work a little bit differently, so they thought preventatively more. So very much, if you have some time, take the time to read this study. But this is the finding that jumped out at me, and I was like, whoa, this is a direct quote. Patient falls are complex because they result from a combination of patient, such as lower leg extremity weakness, environmental, tripping hazards, and system factors. System factors that contribute to patient falls include the attitude that falls are inevitable. How often do we hear that? Well, we're not going to ever get to 0 because patients are always going to fall. Poor teamwork, and an inability to adequately learn from fall events. That's a pretty profound statement, but that's what the results of this survey showed. And so that is why that link to your culture of safety and what your staff believe your environment promotes, that's why it's so important. So take a look at that. And I know a lot of you are doing culture of safety surveys right now. I've probably got 20 going on that have just started and will be going here in the next couple of weeks. And so just a little something different to think about as you're looking at your fall work. To lead into the huddles, if you have not started a fall huddle program, or perhaps you have and you just need a couple extra tools, the University of Nebraska Med Center came up with a great little, it's a pocket guide as well that gives you facilitator tips and just guides on what to follow. And along with that is a tool to fill out that actually dissects the fall that occurred. So this is a good tool that you can use to document all your information. And then when your safe mobility teams or whatever you call your team, fall prevention team, safe mobility, whatever you choose to call them, these are the type of forms you guys should be reviewing as a group. And a lot of times from this information, you can see a true area where your gaps are. So the link to these tools is on the presentation as well, but if you're not doing a huddle and you'd like a little more structure around it, here's a couple of tools to get you started with that. Right now we have a couple of organizations that have begun implementing the BMAT tool, which is the Banner Mobility Assessment Tool for nurses. And so this started at Banner Health System. It is now expanded all across the United States, and a lot of hospitals are using this. And the thing that I find very interesting, and I think it's a good tool. It is painful to get started because everybody needs to understand, excuse me, what level their patients are in their mobility standpoint. But how this is good is this is a good tool that everybody in your hospital, and I'm talking about your imaging areas, your surgery areas, everywhere, areas that you don't really think the fall education is necessary. This actually educates all of your staff on, you know, how much of a fall risk is this patient really? So this is just another tool. You know, some people compare it to, oh, what's another tool like the Morse or you know, the Heinrich or whatever other tool you choose to use. But if you haven't ever looked at the BMAT tool, this in itself is another good tool, and it kind of, well, I don't say kind of, it does increase critical thinking skills as well. So pre-hospitalization risk assessment and education. It does matter. This is very important. So this is a different, kind of a different angle I want to take you guys along right now too. And this is fall prevention can start with your patient and your family and your primary care physician. So this is a really good article that speaks about risk assessments being conducted in primary care practices. You know, I know that this is totally not, I don't want it to be a focus point, but that you can code for that in a primary care practice as well, that you've done a fall risk assessment. Now there are documentation guidelines that have to be followed along with that, but this is the starting point. When patients are being evaluated by their primary care physicians, this is where education can start. And then when we do get them in our facilities, this is where we pick up where they've been left off. So here's a really good article. For those of your hospitals, I know a lot of you have primary care practices that you work closely with, especially with a lot of our rural hospitals and our critical access hospitals. So this is where your collaboration can really come into play. And the tools that are really focused from that primary care practice area, but I have promoted these probably since I started doing this falls leadership about 3 years ago. It's called the STEADY Project, and it's by the CDC, and there are brochures that can be given to patients. Now, this is the patient and family engagement as well. If you look on my slide here, it has all of these different takes for the patient, for family caregivers, you know, staying independent in the home. And so if you go on this website, you can actually see where you can order these resources as well. But these are nice resources to have available in your emergency department. Any information areas that you have for your families as they come to visit their patients. For the patients when they're getting imaging studies or testing or blood drawn, take advantage of those areas and take advantage of getting this type of information out there to you. So a lot of times you can get some of these educational materials. They'll give you like the first 500 free, and then after that you have to start paying for them. But take a look at these materials and think outside the box. Think outside the box of just your nursing units, but think of other areas in your hospitals that you can put this information and share it with your volunteers and share it with your PFAC councils as well. Because you know, if you have foundations that support your PFAC council, maybe that's where funds can come from to purchase these type of materials. But think prevention. Think patient and family engagement with these materials. So I wanted to review just a few resources. Some of these you may have already seen before. The very first one I want to talk about is the Falls Performance Improvement Tool. Some of you have participated in the sprints and the relays that HRET has had, and this is a tool that they created. This is just 2 pages of it. But what this tool is used, it's basically a gap analysis tool. And when you take, say you take 5 to 10 charts of patients that have been harmed from a fall, and you answer all of these questions, it is very evident where your gaps may be. These questions are very specific and targeted for different areas. And so this might be somewhere to start. If you're kind of like, well, we can't find any rhyme or reason in this. If you do take, you know, 5 or 10 of your falls and start answering these questions, and it shouldn't take any more than 15, 20 minutes at tops per chart to answer these questions, you can see a lot of times where your gaps are, and maybe that's where you need to do your focus at. It could be a specific unit, which you probably already know, but you might find a couple of surprises in here. So the whole tool is on the HRET website as well, but I put a little snapshot here of it. There is also on the HRET website, when you go to the topics and you click on falls, there is a list of all of these mobility resources. Several of them I have shared with you in the past. There are a few more on here, and they might be specific to the areas that you're working with. There is a guide for creating a safe environment to prevent toileting-related injuries. So that's another one I know a lot of you have talked about. Also mobility. A lot of you are starting mobility programs. If you are still interested in starting a mobility program and you need some tools and resources, and even maybe a buddy hospital who has already implemented and finding success, please reach out to me. I'll be more than glad to help you get started with that as well. You know, in the Get Up campaign, we showed you that early progressive mobility actually reduces the chance of a patient falling for several reasons. And the added bonus to that is also we see a reduction in CODIs and CLABSIs and pressure injuries because we're getting our patients up and moving sooner. I had a hospital report in my collaborative fall that in baby steps. I always say baby steps, just one thing at a time. And their one thing at a time is getting their patients up out of bed for meals. And that always didn't happen, and now it does. And that does make a difference. And, you know, I talked about in past educational webinars and classes about the heals for meals. You don't go to bed and eat your dinner in bed at night, and regardless of whether you're in the hospital because you're sick or injured, there is healing and validity in getting somebody up, getting their blood flowing, and putting them in a chair at the bedside to eat. So I'll be more than glad to help you with that mobility if you should need some more resources and help with that as well. And as usual, I promote the HRET Change Package. It is a wonderful tool. It is chock full of resources. Some I've shared here. Others, there's some different things to try and encouragement. So if you have mobility teams, make sure that everybody has this access to this in their hands so they could, you know, when I say you need to have that multidisciplinary team and they need to read things like this, it is very much amazing what perspectives come from people who you don't really think are at the heart of fall prevention, especially pharmacists. We've had so many mobility teams that didn't have a pharmacist on that team. And, you know, medication safety is a big part of fall prevention and understanding medicines that patients are on. So make sure you share the HRET Change package for falls as well. And so with that being said, I wanted to open up the lines and see if we have any comments, questions. I welcome people sharing what they're doing right now and if they've seen some improvements. And I also welcome people who want to share their struggles and their trials and what has and hasn't worked. So everybody's lines are now open. And so if you have your mute button on and you want to talk, don't forget to push that. But anybody have anything to share? Or you can type it in the chat box as well. It's a quiet group. Is everybody dreaming of little Butterfingers and Hershey bars dancing in their head? You know, all those ones that are going to be left over because the kids aren't going to be able to trick or treat tonight, and you're going to be forced to eat all 100 of them that came in the bag? Well, all right. Well, I just, as I said, please know that I'm always here to help you guys with any resources that you need, any site visits that you need. I can come out and talk with you if you want, just to one-on-one phone call to run some things by, or if you need help with your data or anything, please don't hesitate to reach out to me. So thank you for your time today, and enjoy the rest of your day.